Good afternoon, everyone. I'm pleased to present the progress of my PhD thesis topic, the impact of navigational systems on CT-guided interventions. My name is Mátyás Rédei. I'm a first-year PhD student, and I'm working at the Medical Imaging Center. And so, throughout my PhD research work, I would like to improve CT-guided interventions with advanced navigational systems. Therefore, we aim 3 specific goals throughout my PhD work, but for the lack of time, I'm going to present the first 2 of them. The first is investigating the safety and effectiveness of navigational systems for patients undergoing CT-guided interventions. There are various types of interventions with each distinct characteristics which make their comparison very challenging, but it's very important to highlight that they share a common initial procedure type, step, the number of needle insertion. Without navigational system, this insertion needs multiple needle manipulation, which can cause more complications and even can extend the waiting list and also increase the radiation. But with navigational system, the irradiation dose can be decreased by 50%. The procedure duration can be decreased by nearly 40%, and even the complications are reduced by 7%. So our clinical question is that does the integration of navigational systems in CT-guided interventions lead to reduction in complications compared to the conventional freehand method? Therefore, we are going to compare the utilization and non-utilization of these navigational systems in patients undergoing CT-guided interventions to assess the outcome parameters such as number of needle manipulation, procedure time, complication rate, and success rate. And we hypothesize that using this navigational system can increase accuracy and safety in CT-guided interventions. This is the search key, and we conducted the systematic search in November 14th in last year, and at the end we managed to hit 36 eligible full text for analysis. The first outcome parameter is number of needle manipulation, which is crucial because the higher the number of needle manipulation, the higher the complication, the longer the procedure. Usually less than 10 needle manipulation is needed during the intervention to reach the proper target. We found the great heterogeneity. Throughout my outcome parameters, we are going to face with great heterogeneity thanks to the fact that they are using different kind of navigational systems and different type of interventions and different type of targeted organs. But overall, we can say that there is a significant reduction by almost 3 number of needle manipulation in these interventions. The second outcome parameter is influenced by the first one, the number of needle manipulation. So it can describe the procedure time. For this plot, it's also we have a high heterogeneity, and overall we could include about 28 studies, both RCTs and cohorts, and the results are parallel in between the 2 type of studies. The overall result is that with navigational systems, it's needed less than 8 minutes to finalize the procedure. But to understand more about procedure time, I would like to present you a subgroup analysis based on the different type of interventions, and I would raise the highlight on biopsies, because these biopsy procedures usually takes about 10 to 30 minutes, and there is a significant reduction of less than 5 minutes in these groups, which is about 25%. The third outcome parameter is complication rates, which is also crucial to assess the safety of these navigational systems. On this plot, we could include 13 studies, both RCTs and cohort studies, and these are overall complication rate during this procedure. Since there is Also, different type of procedures and all complications are included. I would rather present the kind of subgroup analysis on the complication rates, which is the most common complication, what is pneumothorax. On these two plots, there is no significant difference between the utilization and non-utilization of the navigational systems, which is clearly also a good outcome for pneumothorax rate. But with chest tube insertion, I would like to show that for thermal ablation subgroup, there is a significant reduction in this complication. For the last outcome parameter is success rate. We can divide it to technical and diagnostic success rate. Technical success rate is assessed by the operator during the intervention on CT images, where the operator can see whether the needle is well positioned or not. Diagnostic success rate is much more objective. On those, we included just biopsies because the diagnostic success rate is assessed by a pathologist, and if the histological result can show that there is some malignancy or a pathogenic function in the tissue, it is diagnostically positive. So we can see odds ratios favoring the utilization of navigational systems. Regarding technical success rate is 2.13, and regarding diagnostic success rate is 1.81. So our conclusion is that navigational system in CT-guided intervention boosts efficiency, accuracy, and reduce complication by minimizing needle manipulation. And our implication for practice is that these systems should be used during this intervention, and for further research, it's necessary to compare the different type of navigational systems and also identify the best ones for specific CT-guided interventions. As every study, we also have some strengths and limitations. The strength is that this could be a practice-changing research in interventional radiology. It's clinically highly relevant, and we can provide recommendation when and how it is beneficial to use navigational systems. Also, the applicability is challenging because we couldn't divide based on different navigational system. Here is the progress of my first project. We started the manuscript, and the targeted journal is Investigative Radiology. And let's jump to the second project of mine, comparing complication rates per protocol versus standard method in CT-guided pulmonary biopsies. This would be a protocol of randomized control trial. In 2020, the global incidence of lung cancer reached more than 2 million, and it's also increasing. And for treatment, it's necessary to find a histopathological pattern in the lesion. Therefore, percutaneous CT-guided lung biopsy is preferable for peripheral lesions with technical success rate nearly 100% and diagnostic accuracy around 90%. It's also needed with local anesthesia, but on the other hand, it has a high risk factor of pneumothorax and even a 5 to 10% of chest tube insertion. So what is PEARL? PEARL is peri and post-procedural techniques which can be implemented during these interventions. Stands for patient's positioning biopsy side down, needle removing during expiration, autologous blood patch sealing, rapid rollover, and pleural patching. In the previous PEARL study, which is a cohort study, they found a great reduction in pneumothorax, even in chest tube insertion, with the same diagnostic accuracy as the conventional CT-guided method. So our clinical question is that does the PEARL protocol reduce pneumothorax and chest tube insertion rates compared to the standard freehand method? So therefore, we are going to compare the PEARL protocol with the standard technique in patients undergoing CT-guided lung biopsy to assess the pneumothorax and chest tube insertion rates. And also for clinical implication, we would like to implement the protocol in our clinic. I would like to end my presentation with the words of Anna Esho: innovation is the calling card of the future. Thank you for your attention.
Thank you very much for your nice presentation. I have only one question regarding your first project. Do these navigational systems are available in Hungary or maybe in your hospital, or these are just in this research field right now?
Yeah, we are happy and lucky to use one of them for thermal ablation in liver procedure, and the third project of mine is a navigational system associated with the lung biopsy.
Okay, thank you.
I would like to join to the young lady, and regarding on your first project, I would like to ask you what is the dark side, the harmful side of the CT-guided interventions, because you mentioned that is quicker and I think for the patients it's a better option. What is the dark side of this?
I think the clearest dark side is the cost. For this navigational system, it can reach really high costs. There are cheaper ones, but also they have really long learning curves, and they are very new at the market right now. So they cannot be reached very easily. Thanks.
Yeah, I just wanted to ask one question concerning the learning curve, whether these studies included in your meta-analysis take in consideration the learning curve of the operators, or is it excluded from these studies? Because we know that the learning curve makes much more complications than when the operator is already experienced one.
There are studies we excluded because of the learning curve, and there are studies mentioning that they used it for about 1 year, 1.5 years, or they were the one who worked on the development of the device. So therefore, it's causing heterogeneity and lower grade levels.
And what about the freehand? Is it an ultrasound-guided manipulation by the operator, or what does it mean?
Freehand-guided method is guided just with CT scans. The patient is anesthetized on the CT table, and the needle position is checked by the CT scans we are doing, so it works with radiation.
So there is no navigation arm set on the table of the patient?
No.
I see. One more question concerning the first study. You have mentioned that the PTX rate is, how to say, approvable, we can say. Are these studies done only with chest manipulations, or with abdominal exposure was done as well?
With abdominal ones as well.
Yeah.
But
it will decrease effectively the PTX rate.
Yes.
So I would separate these two
but
groups.
They are separated, but for the lack of time, there is another subgroup for abdominal interventions.
Okay, thank you.
Just one last question. Thank you for your presentation. So based on your results, or all your outcomes in favor of the navigational system, so technical success, diagnostics, and the needle manipulation. And one of your limitation is the applicability. So why do you think that's the limitation?
I think the applicability is the limitation because we cannot divide or do sample group analysis based on the different type of navigational system. So we cannot say clearly which kind of navigational system is needed for different type of interventions. But there is clearly a trend that there's a need for different types of them, for lung ablation, for liver ablation.
And you weren't able to analyze this?
No, there is no sufficient data, or because of the confounding that they could be sponsored or favoring the sponsored brand, they usually do not mention the type of navigational system they are using.
All right, yeah, thank you.